welcome to Happy Health Hour. The usual crew are here. Dr. P is here, Dr. M is here, and Nurse Lynda is here. Welcome, everybody. How are you doing?
Good.
Very good.
I hope you're excited about today, because I'm excited. We are talking about reclaiming the heart of medicine with clinical initiatives. And the reason I'm excited is because, Dr. P, let's start with you. What is different about clinical initiatives to medicine as usual? Can you describe what this means?
I don't know what it means, but I'll try to give you my understanding.
Okay.
The problem that in healthcare we often have is we start measuring processes, and the processes become more important than the individual. The individual is subservient to the title called patient. The patient becomes subservient to a title called process. The process is taken over by a title called measures or metrics. For example, I'll give you a very simple example and then I'll let others take over. Quality, how do we measure quality? Patients who have rheumatoid arthritis, how many patients are getting the medication? Now, you're just measuring a process. You're not measuring the outcome. You're not measuring how the person is doing. So what happens if that is what your eventual score is dependent on? Doctors just want to fill the medication. And we had situations where patients who were not taking it, did not want it, could not tolerate it, did not need it. Okay, I'm going to write you this prescription. You need one prescription a year. Fill it, don't take it. Now, where is the person?
Yeah.
We are fulfilling a process, a number, a need for doing something. We just have to do something. And that, I think, is a major deficiency in our present system. But there's much more to be said, so let me pass it on back to you.
You know, before I come, Lynda, I'm going to talk to you in a minute. But for somebody who said, I don't know what they are, you sounded very much like a top drawer expert. I'm just saying that, you started the conversation with, I don't know what it means, but I'll give you my best shot. You sounded like a good expert at. So,
because I really don't know. I mean, measuring a human being, measuring the wellness of a human being, how do you measure it? So you create outcomes, which is okay too, which is better. How many people fell? How many people had an amputation? But if we are really taking a step back, we need to start touching the human being, and how do we suddenly the measures start dropping off? You see what I'm saying? So I can't define it.
I sort of do, but I'm still going to call you an expert because you sound like an expert to me. So, Lynda, you wanted to have this topic. You wanted to discuss this topic. He had support with Dr. M and Dr. P. So, what was your thinking behind first having this as our topic today?
Well, we are in the process of changing our culture a little bit here at Access and going back to the basics. And what does that mean? That means seeing your patient as a human being rather than a list of diagnoses. We have forgotten how to look at our patients, how to listen to them, how to actually see them, take their shoes and socks off, see how they walk, how do they get up and down out of a chair. The way things usually work is the MA, the medical assistant, rooms the patient. The patient's sitting already when the provider walks in the room. If they don't take the time to have them take their shoes and socks off so we can look at their feet, or to have them move around in the exam room, how do you know what their balance is? How do you know what their weaknesses are? How do you know? And this is about seeing your patient as a person, back to the basics, the heart of medicine.
Well, another fabulous answer, very expertly delivered as well. So, Dr. M, this must make you so happy, being the person who is the champion of integrated medicine, to see your colleagues starting to do, or purporting to start doing. I think they've done it all along. I think they cared about the patient all along. But anyway, that's another story. But this must make you so happy that these clinical initiatives, right?
Happy. I don't know. I don't know if that's the right word, but let's say, it's just maybe a step in the right direction. Yeah.
Okay.
Thank you, Linda and Dr. P. I have, a little bit more dimension when it comes to things that I'm doing. We get into the physical, the mental, the spiritual, the social, the economics, their everyday, day-to-day doings. The nutrition and the diet. The diet is just like number one on the list. So I have to know that. And when I look at somebody walk in a room, they're there for me, and I start, asking them about their movement right away. And as Linda said, we have to know how they walk and get up and this and that. So I get up with them and I tell them, okay, I want you to do this, as part of something that, like, as a plan. Like, I'll show them something and I'll have them get up with me, and we work together. I show them how to move their shoulders and their trunk and their legs and their facial muscles and then how to breathe, and things like that. So I just kind of incorporate all of that, and it's all relevant. And as Dr. P said, what are we doing? We have to look at a person, human, right? And there's so many dimensions to us. So if I don't hit those dimensions, I'm not doing my full, I'm not doing my full care, because, there's so many interrelated factors here, and it's not just about them taking their taking a step or two. There's so much, and we can't possibly do that in one little setting, and it takes multiple visitations and so on. So there's a lot to this picture, and I'm hoping that with Linda's input, we really can educate people more on all that goes into the individual.
So I'm absolutely surrounded by three experts, because Dr. M, the way you make that sound, I would never have thought about this before. Obviously, I'm not a medical doctor, but I would never have thought about this. But the way you make it sound so simple, it just hits me and right in the center. And I'm thinking, oh right, surely all medicine is like this. And then I have to remind myself, no, not all medicine is like this. Even from my own experience with my own general practitioner, it isn't like this. So, but I love the way, talking of expertise, I love the way the three of you give slightly different dimension, and you demonstrate disagreement sometimes with real kindness and professionalism and integrity. I really love that about how we interact on this show. Dr. P, we talked about these clinical initiatives. Two topics that I want to hit. You hit them the way you want to hit them, and you can pretend you don't know what it is to begin with if you want. But education. So this must take, Linda talked about there's a culture change going on. So how are you educating your guys? And start touching on which clinical initiatives that you're first embarking on.
So our education is multidimensional. Starts, of course, with the education of the person who is trying to educate others. First, that is a thought process. So we have to learn and educate. And we usually, the way we do it is 4, 5, 6 people, we go back and forth with each other and we argue. And when Linda realizes that I'm right, then we come to an agreement. So starts with that. Once we have all educated ourselves about the theme and we do our research.
Hold on, Dr. P. I just want to ask, and how many times does Dr. M have to roll her eyes to the ceiling before you realise that you need to stop talking?
Invariably, always, but
Oh,
that's a
very
different
yours.
matter.
Okay,
Yeah.
okay. We just needed to get over. We needed the
Yes.
audience to become aware of that. So
Yes,
please
absolutely.
continue.
I would be
Actually,
the yeah.
actually, we are simpatico, I think.
Okay, okay. I shouldn't have
Yes.
interrupted Dr.
So
P. Dr. P, please
educating
continue.
oneself is the beginning of true education.
Yeah.
Second is our providers, our staff, making them aware of the issues. And we have to find something that they all relate to, what an emotional hook, as Linda calls it. What are we trying to do? Preventing falls. What is our goal? Saving toes. Why do we want to save toes? If you don't save toes, you don't save lives. You reduce pain, mortality. That clicks somewhere. Then taking it to the patient. And human beings, education has to be an iterative process, a reiterative process. And as studies have shown, you know better about it than I, most of the knowledge is lost by the time they leave the room. By the time they leave the room, they've forgotten 60 to 70% of what you have said. By the time they leave the office, they forget 90 to 95% of what you have said. By the time they reach home, they remember nothing. But that's a different story because those are my patients. But usually 5 to 10% is what people remember. I'll pass it on to you.
Linda, I think I'm glad Dr. P has stopped talking because we can get some sensible conversation now. So Linda, talk about some of he talked about actually very interesting points which I'll come back to on education. But first, talk to me about the initiatives broadly. How many initiatives? Who's involved? How many providers are taking them up? Talk about the initiatives that so that our viewers know that then it's not just theoretical. These are real things happening at Access Healthcare.
Yes, they are. We have like a committee of upper management, all clinical people, and we discuss the hot topics, the things that we're seeing with our patients or not seeing with our patients, as the case may be. And going back to the basics is part of all of this. What are we missing? What is it that we need to be aware of? So we started with falls. We didn't invent that. The government, the CDC and OSHA and AHRQ, all of these government agencies have been trying to get physicians of all specialties to take a look at how we can prevent falls because of the horrible physical, emotional, and financial outcomes from a fall with a fracture. There's some very, very scary statistics. And so we decided we would start with that. And I think what we thought was starting with that initiative actually was the gateway to other things. So like the next initiative.
Why was it a gateway?
It's a gateway because when you do the assessment to try to figure out what a patient's risk factor for a fall is, or what caused a fall. So these are patients who haven't fallen yet. What's their risk factor? What are the underlying things? And now that's forcing us to look at what are their underlying diseases? What are the medications they're on? What's really going on with them? That's why you get them up and walking and doing different things so you can see and you can test and it tells you where to go with your exam. It tells you where to go with what you're talking about with the patient. And so if you have that as your starting point, now you look at their underlying diseases. Maybe they have a substance use disorder. That's going to be the next initiative. Maybe they're losing, they've got very bad circulation in their feet and they're going to lose their toes, which is going to lead to losing a foot, which might lead to losing part of a leg, which will lead to losing your life. Maybe they're obese, morbidly obese, which has another whole cascade to itself, but it's also part of fall risk.
Yeah.
As is dementia. and major depressive disorder. And, and that's how we chose the initiatives. I think we decided there were 8 to start with.
So very quickly, Lynda, because then I want to talk to Dr. M about education, because I'm really taken by something Dr. P said. Just give us a sense of the number of providers really taking part in these initiatives.
Well, we have 162 providers, physicians, DOs, also physician mid-levels, PAs, and APRNs. All of them have to take the mandatory training on each and every one of these initiatives.
Right.
So
Okay.
there's a mandatory training, there's an assessment tool, there's a protocol, and then there's all the things, the exam, the whole 9 yards. And each one of these initiatives has all of those elements. So, they have to take the course, they have to pass the quiz, and then we audit to see if they're doing what we're asking them to do.
Oh, super robust then. Dr. M, Dr. P said something about education, which I'm really intrigued about. He talked about finding the hook, finding the emotional hook with not just patients, with providers, and understanding the emotional connection. That sounds really advanced. Is this an accident, or is this just part of your culture at Access and the Welcome Centre? I'm really intrigued by how you integrate education into how people learn. It's just not a tick box approach you have there. You have something. You have a way of managing the educational process so that culturally there's adoption and buy-in from everybody. How did you manage that culture?
As far as where I'm coming from, the people that I've mentored, we bring people in, and all of us as people who've been here before, we mentor and we show them, reinforcing the things that they learn through LMS and their own education. I try to, show by example. People hear me. I have nurse practitioners who work with me, and they're taking in, a lot of what I do. They kind of almost mimicking me in trying to get deeper into the patient, looking at the patient from, a more holistic standpoint. So they're asking questions, and they're getting better at it. Asking all the relevant questions that will get the answers as to why they have what they have. So in terms of education, I've tried to extend my education, in the realm of integrating all the alternatives and everything else, bringing that into conventional and kind of using whatever tools I need to customize for that particular individual. And so people are picking up on that. They're seeing what I'm doing in my office, and I would hope that others are being good mentors to the staff around them. And even the staff that works, my whole staff in the office, they're also picking up on things that I show and talk about, and so it's kind of reinforced all around. Their self-care, their diets, the way they exercise. I'll ask them, have you been? How is your blood pressure these days? How are you doing? And there's feedback. So I do it with everybody. It's not just patient in front of me. So I'm kind of getting it all in there, and we're all teaching each other. I learn from everybody every day. Yeah. And, so it's an exchange. It's always an exchange. So education is really the crux of it, teaching people how to be better, how to improve their lives, and to extend that to other people and share what they know, and it has to make sense. It has to be practical. And, that's the only way we can do it, by education and reinforcement of the education. It's not just you tell them and they're going to take it away. Like my husband said, they 90% is gone by the time they're home. Well, I give out written materials.
Yeah.
Or I reference something that they can go to. So I'd like to hand them something before they leave, or I write it out myself, or it's already pre-written.
Amazing. I'm genuinely impressed because when people talk about education, it's very often robust, slightly tick box, but there's deep thought gone into this. But Dr. P, is there a downside to this in terms of, are you having to increase the amount of documentation because of these clinical initiatives? Does that lead to more cost? Are you becoming less efficient? Are there downsides to this, or am I barking up the wrong tree?
Yeah, so when I was growing up, there was this little game we played as children, and I think I'm doing that. Have you ever done this? You have to do this at the same time. It has to go faster, faster. So doctors are doing that. They're buried by a process while they have to deal with a person. And you bury them with the documentation. And it's good to document. Documentation is important. But we're not having them document the thought. They're so buried with documenting process, as I said, things that probably could be caught in a better way somehow, or with a better design of the whole healthcare system. So when I'm dealing with a person, I'm so busy typing away that I'm losing that touch, and especially because we have introduced an intermediary. It was probably a little easier when I was writing with my hand, and that may be somewhere the brain connecting emotionally, but that's how I was trained. You wrote, but you're paying attention to the person. It's difficult. One thing we try, so that we lose that. We try to have a balance, and we lose that. We tried, as we grew the company, to always have a leadership that was clinical and led by doctors or people who have been through the system. Like Lynda is education. Lynda, it's not someone who's coming from an education field, because she knows the field and now she has expanded her horizons. That was a good thing. But that's when we realize how little we know. And that's my definition of an expert. An expert is one who knows less and less about more and more. But again, sorry.
I'm totally seeing Linda's laughing. I've got my head in my hands, and Dr. M is shaking her head. You're going to have to explain that a little bit more, Dr. P.
Okay, who is an expert today? A guy who knows this one thing to be done in AI, a person who knows one little thing in ACs, or in ophthalmology. We used to have, not just ophthalmology is about the eyes, right? We had a department that dealt with the cornea, one department that dealt with the retina, one department that dealt with the left eye, one department that forget it. No, so come on. Is there someone who deals with the eye per se? And they would argue with each other. Is there someone who deals with a human being with an eye? I mean, so it limits us. We know less and less about more and more. There's so much we don't know.
Okay, I have understood that now. Thank you for explaining
Takes a while.
that.
You're an educationist. It'll take a while.
All three of us are grateful that you took the time to tell that. But what you're saying is that this clinical approach, it doesn't necessarily lead to more documentation and more process. It actually, the navigation is not, but you're also saying the navigation is not easy, but it's doable. Am I putting words in your mouth, or is that
Yes, right? Yes, but that's okay. You do that. No, but the problem is first documenting that the patient has certain issues. So questionnaire of what? What did we have? 30 questions, Lynda? Everyone rebelled. All the doctor says it's too much. We don't have time for this. So we try to pare it down to say 10 things, 12 things. But even that, when a person is waiting, it's good to know these, but then they have buried by questionnaires, just like we are buried by answers. Patients are buried by questionnaires. They don't like them anymore. They get calls with 1 hour calls for answering all the things that CMS wants to know. So they don't want to deal with it. So we have to kind of explain to them. If we explain, then it starts making sense. But then once it's done, it's quite a revelation. In one page, you can see almost how the person is you start seeing the person in a slightly different way. You start seeing the person, how they're coming in, how they're walking into your room. You start seeing, okay, how does this person getting up? Because otherwise they're on the exam table, you examine them, you're done. No, now you're looking at you're widening the process. You're widening your horizon. Then sometimes you see a little bit more. So when you say an expert, I'm trying to become a non-expert, if that makes sense.
Yeah, in a way, absolutely.
Yes.
Thank you. Lynda, because we don't have much time left, I've got a question for you and a question for Dr. M. So talk about the future of these clinical initiatives over the medium term, over the next 12, 24 months. What's going to happen at Access with these clinical initiatives?
Well, hopefully all of our increased observation will drive prevention. The whole idea behind this is to work with the risk factors to prevent things from getting worse. You can't fix what you don't know is broken. So if you take a few moments to do a little more, accurate diagnosing starts with observation and listening. And because we are going back to the basics, because we are trying to change the behaviors we have fallen into over the years, we're trying to go back to what we learned in medical school, to what we learned in nursing school. We're trying to go back. And it's not it's not, what am I trying to say? It's not a regression, it's a renewal. And because we are going back to these things and we're seeing our patients a different way, we have a much better chance of giving them better outcomes because we're going to stop it before it gets going.
Love your passion.
We're looking for the smoke. We're going to put the fire out with the smoke.
Love your passion, Lynda. Thank you. Dr. M, the last word is to you. And the question is really, if you could add one thing, I know you don't want to add just one thing, but if there was one thing you could add to these clinical initiatives, or one dimension, not one thing, say one dimension, what would you like to add to these clinical initiatives for over the next 12, 18 months?
Yeah, that's not an easy answer at all, Nawtej. But because there are several, but to really get into the patient's deep emotional state. I like to get deep into our patients' heads, literally, and what they have been through. I go back to early times in their life, and that's not paid a lot of mind in these in these times, conventional practice. People not looking at what the patient or the person, excuse me, went through when they were very young, what led up to what's happening now. And it frustrates me because, we just talk about diagnoses, everything is interrelated, and then we separate and parse them out into diagnoses, but everything they have at this point in their life is kind of one big thing with a lot of different symptoms, and we've got to give, each of those symptoms a name. It's mental depression, and then it's cardiomyopathy, and it's this, and everything is separated. That's the way it's done. If we can just, pull it all together as one, I would like to see that. So maybe that's the thing, to see it all come together. The past mental, emotional state of the person is really what is governing what's happening right now to them in the present moment. So so that takes a lot. That takes time. It takes a lot of patience and real empathy. Really interacting face to face, looking at their body, touching them, and not touching the computer. So I'd like to see that we're like Dr. P said, go back to writing. Just jot down the notes. Note very salient things that the person is saying or showing you, and like we can even write, okay, person is twitching or person is sweating, or just make notation, then get to the computer later. So yes. I'm very much into hands-on, not using a computer, getting back to simple pen and paper. I really wish that could happen again. I know it's going to be a struggle, but some of us are just going to do it that way, and then we'll transfer it to the artificial, whatever you want to call it. But I just think a pen and a paper is the most natural way to go, or even not, just to remember everything, use the mind and remember without writing anything, just being there with the person. And then you can transcribe it all later. But of course, we all forget, and I forgot that detail. So that's why the pen is helpful, to jot notes. I think that would be the way to go, just looking deeper and then taking it, from that perspective.
It was in fact a very unfair question for you to ask if there was one thing. But actually, the way you answered that was superb, because you brought in everything into one thing, which is find out the history of the person. Spend some time with the person and find out the history of the person.
Yeah.
Thank you for answering it very, very beautifully. I am really enjoying these sessions with you three now, simply because I get to ask loads of questions and I get free medical advice. What's not to love about this show?
Well, at least one of us is enjoying it, so that's a good thing.
You better watch your step, Dr. P. We are out of time. Dr. P, Dr. M, Lynda, thank you so much. Will you be here next week?
Yes.
As long as we're breathing and our hearts are beating and everything. Yeah.
It's
God willing and the creek don't rise.
It's very difficult to predict anything, especially about the future. So, well.
Okay, but I'm going to see you all three next week. So great talking to you. Thank you so much. Bye-bye, everybody. And it's bye-bye from Vedere University. Bye-bye.